Now that we're situated, thank you all very much, and I would like to thank the Department of Veterans Affairs for joining us today. The members who are here are, members of the VA administration that are here are Alfred Montoya, who is Deputy Assistant Undersecretary for Health for Operations in the Office of the Deputy Undersecretary for Health. Accompanying Mr. Montoya today are Dr. Scott Hartron, the Executive Director for the Office of Geriatrics and Extended Care, and Mr. David Perry, the Chief Officer with the VHA's Workforce Management. Mr. Montoya, you are now recognized for 5 minutes to present the department's testimony.
Good afternoon, Chairwoman Miller-Meeks, Ranking Member Braunley, and other members of the subcommittee. First, I would like to apologize formally for the lateness of our testimony. We certainly do heed your comments about that in the beginning, and certainly will work towards getting our testimony on a more timely fashion. So thank you for those comments. Thank you for inviting us here today to present our view on several bills that would affect VA programs and services. Joining me today are Mr. David Perry, Chief Officer, Workforce Management and Consulting, and Dr. Scotty Hartroft, Executive Director, Geriatrics and Extended Care. VA is grateful for the committee's dedication to providing VA the authority and resources related to access, eligibility, and staffing. H.R. 41 would require VA to ensure that whenever a covered veteran contacts VA by telephone to request the scheduling of an appointment, the scheduling for the appointment occurred during the telephone call. VA does not support this bill. VA already has the authority to do what this bill proposes, and it does so whenever possible. However, requirements for clinical review and determinations of eligibility are not always possible, nor desired by the veteran at the time of a phone call to complete simultaneous appointment scheduling. Additionally, some types of care require specific eligibility, and it is not always possible to know that information during a telephone call. H.R. 366 would add a new subsection that would state that persons VA has determined served in Vietnam as a member of the Armed Forces of the Republic of Korea between January 9th, 1962 and May 7th, 1975 would be eligible for benefits as a discharged member of the Armed Forces of a government. VA does not support this bill. In addition to a technical concern and equity concerns for other nations, there is also a concern about expanding healthcare eligibility to persons who served in armed forces of other nations before we can fully address expanding eligibility to veterans in priority groups not covered within our own current veteran population. We appreciate the close collaboration in addressing some of the concerns VA identified with previous versions of H.R. 542. We believe the current version is much improved and is a demonstration of the benefits of VA and Congress working together. VA generally supports this bill if amended, although our positions vary as noted in my written statement. H.R. 562 would require VA to permit a member of Congress to use a VA facility for the purposes of meeting with constituents. VA opposes this bill because we object to the prescriptive requirements of the bill. Facilities also raise unique concerns that would make placement of an office for a member of Congress inappropriate. H.R. 693 would require VA to notify Congress within 90 days of detailing a VA-MC director to a different position in VA. VA supports this if amended. If unamended, this bill may impact continuity of operations as well as ongoing projects and initiatives that require a VA-MC director's leadership. Section 2 of H.R. 754 would establish a commission on eligibility to examine eligibility for VA healthcare. VA has concerns with the proposed bill and opposes it as currently written. We appreciate the committee's interest in assessing eligibility for VA healthcare. Eligibility determinations can be quite complex because veterans and other beneficiaries may qualify for the same or similar services under multiple laws. H.R. 808 would require VA to ensure that there is not fewer than one patient advocate for every 13,500 veterans, and that highly rural veterans may access the services of patient advocates. Over the last few years, the role of patient advocates has expanded, and we are working to identify the best approach to ensuring veterans can access patient advocacy services as needed to support the delivery of their care. Section 2 of H.R. 1089 would require VA to ensure that each medical center director submits to the Secretary, the Committees on Veterans Affairs of the House of Representatives and the Senate, and the appropriate members of Congress an annual fact sheet with certain statistical information with respect to the year covered by the annual fact sheet. VA does not support this bill. We understand the fundamental interest or concern of the bill, but VA already provides significant information online about patient experience, wait times, and quality for each medical center. The requirements for each director to submit to Congress directly on an annual basis these fact sheets would be very involved, requiring each facility to establish redundant processes and systems and incur significant additional costs. Finally, VA supports Section 2 of H.R. 1256. Setting a 5-year term could provide VA with continuity of operations when there is a change in presidential administrations and could allow VA to continue providing support and care to our nation's veterans without interruption. It would also give VA the flexibility to recruit and retain highly qualified executives with various experience to fill these critical leadership positions. This concludes my statement. We would be happy to answer any questions you or members of the subcommittee may have. Thank you.
Thank you for your testimony, Mr. Montoya. I will now yield myself 5 minutes. Mr. Montoya, currently when a veteran contacts the department by telephone to request the scheduling of an appointment and the request cannot be accommodated during that phone call, what is the typical process for follow-up?
Yeah, Chairwoman, thank you so much for that question. When we look at scheduling and when a veteran calls in, I'll actually use some of my own examples as a veteran who gets 100% of my care in the VA. So as that veteran calls in, if they're not able to make that appointment for one reason or another, that eligibility or determination of the clinical reason would then go on to another provider or clinical staff to be able to help schedule that appointment. So a good example of this would be dental. Dental is one of those very intricate appointment types where there needs to be some evaluation of the benefit as well as the clinical application of the appointment.
On average, then, how long does it take for a veteran to schedule that scheduled appointment?
Yeah, so I'm very happy to actually share some of our wait time data that we do have for the community. And so for the exact time frame as far as when it takes a veteran to get their appointment scheduled, I'll certainly get back to you on that one for the record. I will tell you, in some cases, we do this already the same time that that veteran calls in. So if it's a very basic appointment, such as primary care or mental health, in many cases, we can do that the same day. And in some cases, we actually have a clinical contact center that does that 24/7, 365 days a year.
So I'll let you know that I'm a physician, and when patients call me to schedule an appointment, we schedule that appointment the same day. We don't have them call back. If they walk in, I see them. I don't ask for their insurance or what their benefits are. I take care of that patient. In addition to which, I understand the challenges that you're having, but there are oftentimes when veterans have extreme need and need to be addressed. And we know one of those because we have a bill named after a veteran who committed suicide who could not get into the VA and was declined service or not made an appointment in a timely fashion. So it's a bill that I support. I understand the challenges that you face at the VA, but I think that sometimes when there's a will, there's a way, and perhaps we need to give the VA the will to make the way happen. When a veteran contacts a call center, shouldn't they be able to complete that scheduling request in a single call? It sounds like you're supportive of that.
Yes, ma'am, and thank you for that. And as I did mention in my previous answer, many of our basic appointments, such as primary care or mental health, those are scheduled on the same day. And in fact, when veterans do call into our clinical contact centers, they are able to schedule those appointments. Where it does actually present an opportunity or a challenge is when there are some of those more complex medical appointments, such as cardiology or dental, as I mentioned with my previous example, where it does take more time to dig into what the eligibility is, what the clinical concern is, to make sure that we're scheduling the right appointment for that veteran at the right time.
Okay. In your view, how would veterans benefit from having representatives of their members of Congress available in VA facilities during business hours?
Yeah, thank you so much for that question as well. As a former medical center director of 3 different stations, I can't underscore enough the importance of the relationship with our congressional stakeholders in the community. Oftentimes we hear those concerns from them first and foremost about our veterans. And when they're in the facility, we actually run into a couple of concerns. First and foremost, our primary reason for our medical centers is to provide that space for clinical care. Oftentimes in our medical center, there is not enough space to be able to do that. And so we do feel that having that blanket requirement to provide office space would detract from that clinical care or the potential for that clinical care to be provided. Additionally, when you look at it, there are other things that come alongside that, such as parking, the flow going into the campuses and the like, that tend to be a little detracting.
So your conference rooms are full 24/7?
They are not, in fact. Thank you for that, because I think there are the opportunities for our congressional members to, on an ad hoc basis, to be able to coordinate space within those medical centers. All they have to do is reach out to their medical center director, and they can work through the process of making that happen.
And thank you very much. As a fellow veteran, I think sometimes it's good to go into the VA hospital when you're unannounced and not having an officially guided tour. Thank you, and I'm going to yield 5 minutes to Ranking Member Brownlee.
Thank you, Madam Chair. Appreciate it. Dr. Hartroff, I wanted to ask you a couple of quick questions here at the beginning. And I would just appreciate if you could just answer yes or no, okay? So is home and community-based care good for veterans? Do veterans who use home and community care generally have positive experiences and good health outcomes?
Yes, ma'am.
Is home and community-based care usually less expensive than institutionalized care?
Yes, ma'am, in most cases.
How many veterans does VA expect would benefit by increasing, in Section 2 of the bill, by increasing the cap to 100%?
We don't have the exact number, but the populations that are primarily affected by the current cap are veterans with ALS and also some spinal cord injury and disorder patients, and especially when they need ventilator care or 24/7 care, the primary population that most likely has issues with the cap.
So in no way does the bill say that every veteran who receives home-based care would use the full amount?
No, ma'am.
It would be a much smaller amount.
We would estimate that.
Yeah. Well, you know, you estimated a 1.2 approximately $1 billion in terms of the cost. Mr. Montoya, maybe you know this, but there had to be some kind of an assumption of how many veterans would utilize the cap at 100%. Roughly 200, 500?
I can bring those to you for the record, exact numbers, but again, we were primarily looking at those populations that were specifically hitting the cap.
Okay, I'm looking for like exact numbers because we have some work to do with CBO. So, I would definitely like those numbers. So, do you think the way CBO, because CBO did score this at, roughly $24 billion, which is, quite different from your $1.2 billion, that's quite a difference. Do you think that what they did was they assumed that every veteran that would utilize the home-based care, they scored it at 100%? Do you think that's how they possibly came up with a $24 billion figure?
My apologies, but I can't really comment on the CBO's estimates or methodology.
The secretary said the same thing.
Yes, ma'am.
So if you're not going to comment on this, then I need you to comment on how you came to your conclusion of what you think the bill costs.
Yes, ma'am.
Because we've got to figure out this discrepancy, okay? Yes, okay. I guess then, I would just go on to ask did the CBO ask the VA for data to make their assessments of costs?
I'm unaware and can't comment on how much they reached out.
Wait, are you unaware or you can't comment?
I'm unaware.
Okay, good. All right, so unaware. So we've just got to kind of get to the bottom of this. I know on the Senate side of the bill, they're equally as interested in figuring this out, and I know this is a section of the bill that the VA absolutely supports. So, again, if you can give me the exact numbers for the record, I would appreciate it. And with that, I yield back.
Thank you, Representative Brownlee. I'd now like to recognize General Bergman for 5 minutes.
Thank you, Madam Chairwoman. As you all know, I guess let's start with first things first. To any of our fellow Vietnam veterans, March 29th, several years ago, was designated Vietnam Veterans Day, Welcome Home. I would like to extend that welcome home to all our fellow brothers and sisters and for all of you in the VSOs and the VA community who serve. In my case, my generation of veterans, it's not too little too late, but it was too late for some. And as we look at providing care for veterans now in their 70s and 80s, that the dynamics of healthcare have changed. So with the reason I would start with that is that, you know, with HR 542, the Elizabeth Dole Community-Based Services for Veterans and Caregiver Act, Mr. Montoya, what does VA consider to be the cost of 100% institutional care? Now, I know it could possibly vary by geography or that cost of, you know, living, whatever, but what factors go into determining that cost?
Yeah, General, thank you so much for that question. And for that, I'm going to actually turn to my colleague, Dr. Hartroft, to be able to answer this.
Okay.
Yes, and yes, sir. And it does vary from region to region, as you're aware. But what we usually look at is the average cost for a region for the VA Community Living Center is kind of what we look at, and then we adjust that cap with the 65% with the average. So that's kind of how we peg to that.
So when we're costing out then what we're going to do with, if you will, community-based services, do you feel that you have here's the cost of providing this in Roanoke, Virginia, or Escanaba, Michigan, that you can compare and contrast the costs associated with home-based health care, that we're not using a metric that doesn't really match the geographic area, so you can determine how much this is going to cost?
That's why we currently support not only the 100%, but then also the waiver availability for both certain conditions that exceed that. But yes, we would be interested in meeting and going specific into VA methodologies in more detail if you're interested.
We accept and understand that there could be cost variances in different parts of the country. But unless VA can, through your procedures for evaluating cost, give us, as members of Congress who would appropriate money to the VA for, you know, general funds or specific programs, sometimes we get a little nervous that we're not getting the right cost benefit for the dollar. So I for one like to see numbers, and I'm not afraid of cost comparisons because it is worth the value or it's not. And how do we balance that spectrum of care? Because if we and this is kind of a partnership between the House and VA, don't have our fiscal act together when it comes to implementing good programs for care, the confidence that the veterans and their families, and even within your systems, within your VISNs, one might feel handicapped, you know, by the numbers, other one might feel advantaged by the numbers because it came out in their favor. So I guess, I see my time is running out here. Anything that the VA can do to give realistic numbers for all of us to take a look at as we make these decisions is going to be helpful in the end to the care we provide for the veterans. And in the end, all of us will be proud of what we did, and it will vary a little bit. So I just wanted to say thank you for all you do, and let's not quit, because we've got a lot of veterans out there and their families who are counting on us. So with that, Madam Chairwoman, I yield back.
Thank you. The chair now recognizes Representative Budzinski from Illinois for 5 minutes.
Thank you, Chairwoman. It's great to be with all of you. Thank you for being here. I actually had a question I wanted to ask about HR 542, the Elizabeth Dole Home Care Act, introduced actually by Ranking Member Brownlee. I've heard from many of the veterans back in my district and from several VSOs on the need to enable elderly and disabled veterans to be able to enjoy a higher quality of life at home as they age, as well as the increasing need to support their caregivers. According to the VA Geriatric and Gerontology Advisory Committee, over half of the VHA enrolled veterans are 65 or older, and this population is only increasing, meaning we need to take immediate action to support long-term care and invest in VA's home and community-based services, especially those in rural areas like the district that I represent, where healthcare options are already limited. So really, my first question is for anyone on the panel. What challenges do current caregivers and elderly veterans face, and how do you think this bill in particular works to address some of those concerns?
Thank you for that question, ma'am. Actually, this bill has been very helpful in us aligning our timelines. As y'all may be aware, we currently had a multi-year expansion for many of our programs in home community-based, and due to feedback from, and we'd previously said we were going to make vet-directed care be available at all VAs over 5 years. But recently, due to feedback from this subcommittee and others and external stakeholders, we've actually compressed that now to where we're going to do it over 8 quarters. So we're going to go from 71 sites that were available in 2022 to where we're going to add over 70 more sites over the next 8 quarters. We also were expanding the number of home-based primary care and also medical foster home, which isn't a program that's well known. So right now, we've also made a homemaker home health care, purchase skilled home care, and home-based primary care is now available at all VAs. So now we're working on getting that vet-directed care and medical foster home to all VAs, as well as trying to make veterans known. I think some of the barriers, of course, is especially in rural areas, and it's not, and it's a problem for all of the American demographics, not just for veterans, in the sense that there may not be many vendors or home health care agencies in many of the rural areas or highly rural areas. And that's why many people really like the veteran-directed care program, where they can hire a family member, neighbor, and others to fill in that gap. And that has really helped us in many significant rural areas. So we're also trying to push the limits when it comes to telehealth and other modalities to really kind of improve access to our rural veterans and others who can't get it by traditional means.
Right, that's great to hear. And I actually have a follow-up question in the same vein. There's also critical need to address the complex and unique mental health concerns, of course, of aging vets. Again, for anyone on the panel, how can this bill help address the behavioral health concerns older veterans are facing today?
I think for us, especially with behavioral health and mental health, covers many aspects unique to veterans as well as that of aging in itself, with whether you have dementia or other reasons. So we work closely with the Office of Mental Health and Suicide Prevention, and we look at both how we can improve both the home care level as well as making sure that our institutional facilities are aware of veteran-specific unique needs as well as behaviors, especially as you see in certain populations of aging veterans with dementia and other disorders. So a lot of it's education, training, availability of services, and us working closely with the Mental Health Program Office.
Great, thank you. I guess I'd just lastly like to say I'm really a proud co-sponsor of the Elizabeth Dole Home Care Act, and I'm grateful to my colleagues on both sides of the aisle because it does have a lot of really great bipartisan support. So thank you again for being here today, and I yield back my time.
Thank you. The chair now recognizes Representative Von Norden from Wisconsin for 5 minutes.
Thank you very much, Madam Chairwoman. Write this down. I agree with Congressman Takano. So I think that's a first. And he's right. These Korean War veterans served alongside my Uncle Bob, Robert Francis Mulligan, who was nearly killed by a Chinese communist grenade thrown into his pit. They became American citizens. These aren't just random people on the street. So I completely disagree with you, Mr. Montoya. These people deserve the respect that they earn fighting next to our relatives. Did you say you support H.R. 1256? Because I didn't hear that. That's the 5-year term and that sort of stuff.
Yes, sir, we do.
Okay, thank you. I want to talk to you about H.R. 562. I'm 100% disabled service-connected disabled veteran, my care has been outstanding. The one issue that I've had consistently with the VA is the bureaucracy involved with it. I noticed that your testimony was requested a month ago. We got it last night. Could you say that your testimony was lost in the bureaucracy? Probably. Okay, let's put that one there. Senior Chief Mike Day committed suicide 2 days ago. He was shot 27 times in Iraq. His primary weapon was disabled. He drew his pistol and he killed the 3 people in the room that shot him 27 times. We have to have an on-ramp into the VA. I've had good experiences with the VA, but a lot of those people wearing the same hat that I got back there did not. And I'll tell you why. It's because we walk into the VA and you don't know anybody. You don't. If we're able to walk into the VA and see someone who was sent by them to represent them, that's a friendly agent. And I will do anything I possibly can to prevent another damn veteran suicide. So by excluding us, we're sitting in a room, and I've been to I don't know how many VA facilities, so that we can be the friendly on-ramp for our veterans so they can get into the system and not kill themselves, is imperative. And I'm concerned because I do not believe what you just testified. I do not believe that you think there is not enough room for this. I don't believe that. What I do believe is that your agency is concerned about having on-the-ground oversight by congressional people who control your budget, and that is unacceptable. That is putting your job and the jobs of the rest of these cats here in front of my brothers and sisters in arms, and I will not accept that. So you guys need to change your opinion on that. HR 1256 says you can allow for more flexible numbers of assistant undersecretaries, correct?
That is correct.
And you're capped at 8, right? Can you envision any scenario if you have flexible options that number would become 7?
Yeah, so thank you very much for that question, sir. For that, I'm going to turn to Mr. Perry to be able to answer.
Yes, sir. Thank you for that question. I think what we're looking for is the flexibility to not have a predefined number of assistant
I get you.
secretaries.
I'm just asking you a pretty clear question, Mr. Perry. You're capped at 8 right now. Can you envision that ever becoming 7?
It could potentially, yes.
Well, I could potentially grow my hair back, but the chances of that happening are 0, right? So no, this is the problem here. The only one of these things that you vigorously supported was growing the bureaucracy. The only reason your testimony was a month late is because of your bureaucracy. The only problem I've ever had with the VA is with your bureaucracy. So we got to stop this. I'm not going to vote to grow the bureaucracy. I will grow to refine the bureaucracy. I'll vote to make sure that you're empowered to do your job better, that my fellow reps on this panel have the ability to conduct oversight so it can become more efficient, but I'm not voting for this. It's inappropriate. I mean, my goodness, this whole pack of them, the only thing you supported was growing your bureaucracy. That's not good. We cannot have another veteran commit suicide because of bureaucracy. And there's a framed letter on my desk from a veteran, his brother, who wrote me, who committed suicide, and they got the letter 2 days later that he got accepted to the VA because of the bureaucracy. So his request was lost with your testimony, and we've had enough of that. With that, I yield back.
On behalf of the committee, I thank all of our witnesses for their testimony and for joining us today. You are now excused, and we'll wait a moment as the third panel comes to the witness table. Welcome, everyone, and I thank you for your participation today. On our third panel, we have Mr. John Retzer, Assistant National Legislative Director with Disabled American Veterans, Mrs. Tiffany Ellett, the Deputy Director of Health Policy for the American Legion, and Mr. Morgan Brown, National Legislative Director for the Paralyzed Veterans of America. Mr. Retzer, you are now recognized for 5 minutes.
Chairwoman Miller Meeks, Ranking Member Brownlee, and members of the subcommittee, thank you for inviting DAV to testify at this legislative hearing. I will focus my remarks on the bills under consideration today that most affect service-disabled veterans. DAV is pleased to support H.R. 542, the Elizabeth Dole Home Care Act. By 2037, the age cohorts are the greatest need for long-term care, veterans who are at least 85 years, and those who have disability ratings of 70% or higher, which guarantees mandatory long-term care, is expected to grow by almost 600%. Cost of long-term care services support must double by 2037 just to maintain our current services. In order to meet the overwhelming increasing demand for long-term care needs for the veterans in the years ahead, VA must significantly expand and fund home and community-based services as proposed in H.R. 542. The programs are not only more affordable, but often preferred by veterans and their families. We also support the increasing of the expenditure cap for home and community services to create the financial incentives to expand these important services. DAV is pleased to support H.R. 41, the Same-Day Scheduling Act. In the recent years, the Government Accountability Office and others have reviewed VA scheduling process and identified very specific challenges that the Veterans Health Administration has in ensuring all appointments, including those at community care, are scheduled in a timely manner. This legislation would require VA to schedule an appointment during the veteran's telephone call, regardless of the prospective date of the appointment being scheduled. This would improve the current scheduling procedures at the VA and provide more accurate wait time data. DAV also supports H.R. 808. The bill would improve the patient advocates program at VA medical facilities by ensuring there are no fewer than one patient advocate for every 13,500 veterans. Patient advocates play a critical role in assisting veterans to get the care they need. They have direct effect, the ability to address veterans' complaints and resolve issues with access to care. Importantly, patient advocates also assist veterans with clinical appeals. Advocates should be able to provide timely assistance to veterans in accessing health care and the clinical appeals process. Therefore, we recommend additional research be conducted to ensure that the ratio of patient advocate to veterans is adequate and balanced. DAV supports H.R. 693, the Vacant Act, legislation that would limit the detailings of the VA Medical Center Director to the different positions within the department. Staffing shortages and vacancies in the VA healthcare system, especially the critical management positions, can impede the delivery of care for veterans who rely on VA for their care. This legislation would help improve accountability to sustain needed leadership, to ensure VA healthcare runs seamlessly during a period of transition and that veterans' continuity of care and benefits are not disrupted. H.R. 1256 would extend the term of appointment for the Undersecretary for Health to 5 years and remove restrictions for the number of Assistant Undersecretary for Health that can be appointed. We understand the intent of this bill is to provide greater leadership stability at the VHA and believe it would empower the Undersecretary for Health to more effectively manage and carry out their responsibilities to ensure veterans' health care needs are met. While DAV does not have a resolution that speaks to this issue, we have no objections to moving this bill forward. The final bill I will comment on is H.R. 754. This legislation would establish a commission to examine policies guiding veterans' health care eligibility and make recommendations. If advisable, make changes. DAV is concerned that previous reform efforts have proposed to diminish the size and scope of the veterans' health care system, whether by proposing changes in eligibility to limit the number of veterans who may have received care, or by pressing for privatization of the VA medical services. Historically, Congress has made thoughtful decisions about assigning priority for care and eligibility for various veteran groups. Most recently, Congress expanded eligibility for veterans who experienced combat and were exposed to toxic exposures or radiation under the PACT Act, veterans in mental health crisis under the Compact Act. Rather than a commission, we believe Congress should continue to make these decisions in the best interest of veterans by conducting oversight of VA healthcare eligibility and legislating the changes that are deemed necessary. Chairwoman Miller Meeks, this concludes my statement. I'm happy to address questions you or the members of the subcommittee may have.
Thank you, Mr. Ritzner. The chair now recognizes Ms. Ellett. You are recognized for 5 minutes.
I sit before you today as a disabled veteran, a VA patient, and a veteran advocate. I receive all of my care through the Department of Veteran Affairs and have personally experienced the evolution of the VA benefit and healthcare system since my separation from the United States Army in 2013. It is through this lens that I'm able to see what our members see, to feel the frustrations and aggravation they exude when discussing obtaining an appointment, navigating the system, and receiving appropriate care. With their voices in mind, I would like to take this opportunity to touch on a few points. Chairwoman Miller Meeks, Ranking Member Brownlee, and distinguished members of the subcommittee, on behalf of our National Commander, Vincent J. Jim Troyola, and our more than 1.6 million dues-paying members, we thank you for inviting the American Legion to testify today. VA has made a number of changes to appointment scheduling through their website, healthcare facilities, and updated internet applications. However, there are still veterans having difficulty scheduling an appointment within the setting of a phone call to their VA facility. With the current process for appointment scheduling via phone, many veterans are able to successfully obtain an appointment in that time frame. However, others are told they will need to be contacted at a later date, with some going weeks without follow-up. At times, this can make a simple task tedious and cause frustrations. In Dorn VA, Columbia, South Carolina, there's a pilot program where staff can schedule an appointment without spending time on technical issues or information searching. Instead, all necessary information for scheduling is in a single sign-on interface. In this one screen, the scheduler can see all open appointment times and days for not only VA providers, but also for the community care provider to which the veteran was referred. With this type of system, scheduling an appointment takes an average of about 7 minutes. This is ideal for simplifying the scheduling needs of a veteran. The American Legion supports the VA Same-Day Scheduling Act of 2023 and its intent to increase and simplify access to veterans' care. Separately, in 2003, the American Legion dubbed the VA healthcare system a system worth saving, and in doing so created a program where veterans and local VA medical center staff could meet with us to discuss the challenges and successes in delivering and receiving efficient healthcare. In the last 3 trips we've conducted, the American Legion has found that VA patient advocates are utilized by both veterans and VA with the same goal in mind: successful navigation through the VA healthcare system. As expected, with the increase of veterans enrolling in VA care, the patient advocates have a heavy workload and at times are not able to assist veterans to the extent needed. The American Legion supports the Veteran Patient Advocacy Act and the improvements it will bring through establishing a standard of at least 1 advocate per 13,500 veterans. We are also encouraged to see an increase in access to patient advocates for veterans in rural communities. The availability of patient advocates is a priority of the American Legion and will continue to be a focal point when speaking with veterans about their representation as a VA patient. Finally, I would like to address the Elizabeth Dole Home and Community-Based Services for Veterans and Caregivers Act of 2023. Recently, our national commander testified that there is a concern for caregivers and their health. Often, caregivers will put their veterans' health and care above their own, leading them toward poor health and burnout. The American Legion is pleased to see that respite care is addressed in this legislation as it is beneficial to caregivers, their families, and the veterans they care for. We are also pleased to see consideration given to caregivers in terms of support services and education on possible benefits. We also agree that successful transition and care are critical to the overall well-being of both the caregiver and the veteran. As consistently stated by Secretary McDonough, VA has a priority of providing timely world-class health care to veterans. The American Legion supports the necessary legislation to help VA accomplish this endeavor. We've seen VA work to identify deficiencies, and we've seen members of Congress work with VA to create solutions. The American Legion supports VA as they continue to evolve. We also call upon Congress to pass legislation such as these to allow for and encourage VA's evolution toward health equity for veterans. I conclude by thanking Chairwoman Miller Meeks, Ranking Member Brownlee, and this subcommittee for your incredible leadership and for always keeping veterans at the forefront of your mission. It is my privilege to represent the American Legion for this subcommittee, and I look forward to answering any questions you may have.
Thank you, Ms. Ella. The chair now recognizes Mr. Brown. You're recognized for 5 minutes.
Thank you. Chairwoman Miller Meeks, Ranking Member Brownlee, and members of the subcommittee, Paralyzed Veterans of America thanks you for this opportunity to present our views on pending legislation impacting the Department of Veterans Affairs that is before the subcommittee. My written statement covered PVA's positions on the 9 bills being reviewed today, so in the interest of time, I'm going to focus on the one bill that most directly impacts our membership. PVA gives its strongest endorsement to H.R. 542, the Elizabeth Dole Home Care Act, which would make urgently needed improvements to VA's home and community-based services, including several that target our concerns about current program shortfalls. VA projects the demand for long-term care will continue to increase, driven in part by growing numbers of aging veterans and veterans with service-connected disabilities. Expenditures for long-term care will increase as well and are projected to double by 2037. While greater investment in the department's long-term care infrastructure is badly needed, VA must also expand veterans' access to non-institutional programs when appropriate to prevent or delay nursing home care and to reduce costs. Fixing VA's challenges to meet veterans' long-term care needs will be difficult because it is a multidimensional problem that requires a comprehensive solution. Section 2 of this bill raises the cap on how much VA can pay for the cost of home care. Currently, VA is prohibited from spending more than 65% of what it would cost to care for the veteran in a nursing home. When VA reaches this cap, the department can either place the veteran into a VA or community care facility at a significantly higher cost or rely on the veteran's caregivers, who are often family members, to bear the extra burden. Depending on the services available in their area, some veterans must turn to their state's Medicaid program to receive the care they need, even for service-connected disabilities. Last month, the Senate Veterans Affairs Committee advanced a similar version of this bill without the language raising VA's cap on care, primarily due to its cost. CBO's score for this section is perplexing because only a few hundred veterans are currently exceeding the 65% threshold. Some may need rates to be raised to the full cost of nursing home care, but the majority would not. VA is committed to enhancing and maintaining the quality of life for veterans, but the current limitations on the cap of services is contrary to this vision. Nothing in this legislation expands the number of veterans in this category, and the number of them in this situation is relatively stable from year to year. We recommend the subcommittee work with CBO and your Senate counterparts to review the current calculations to determine their accuracy. Section 4 of the bill requires the VA to administer programs like veterans-directed care at all VA medical centers within 2 years. The VDC program allows veterans to receive HCBS in a consumer-directed way and is designed for veterans who need personal care services and help with their activities of daily living. Last year, the VA announced plans to expand the VDC program to 75 additional sites over a 5-year period, and we were pleased when VA's Undersecretary for Health recently directed VHA to accelerate that timeline. We understand several sites may be ready to launch their programs, but lack the financial resources to do so. We urge Congress to provide the necessary funding so every VA medical center can offer a robust VDC program as quickly as possible. And finally, even when veterans have access to programs like VDC or Homemaker Home Health, it can be challenging to find home care workers. One PVA member told us he regularly spends weekends in bed because no staff is available to assist him, and he is depressed and frustrated because he can't find the direct care workers he needs. The shortage of caregivers or direct care workers is not unique to VA. Across the country, there is an increasing shortage of direct care workers, and a national effort is needed to expand and strengthen the workforce. We believe the pilot program established in Section 7 would lessen the difficulty in finding direct care workers at the sites VA selects and may reveal additional ways the VA could alleviate this problem for many veterans nationwide. I close again by stressing that this important bill addresses several major concerns for catastrophically disabled veterans, and we urge Congress to pass the Elizabeth Dole Act this year. And I thank you again for this opportunity to share our views on this legislation, and I'm happy to answer any questions you may have.
Thank you so much, Mr. Brown. I'm going to go last as my prerogative. I think my predecessor did that as well, so I'm now going to recognize Ranking Member Brownlee for 5 minutes.
Thank you, Madam Chair. Mr. Brown, thank you for your testimony. Given the population of veterans that PVA serves, I was sadly unsurprised to see the significant challenges veterans and their families face due to statutory cap on how much VA can spend on home care you highlighted in your testimony. So for those who didn't get a chance to read his testimony or review it, would you briefly highlight some of those issues and the impact on veterans' quality of life?
Certainly. So we have numerous veterans that have, their family is attempting to provide their care, and because of the cap, and VA has limited the number of hours, they have to make a choice, basically. They're forced to choose between going into either a VA facility or into a local facility, which oftentimes provides them a lesser quality of care, or to have the family assume that burden. And in many cases, it is the family that's attempting to do the right thing here and to care for their loved one in the home. Many of these veterans, and I believe it was touched on earlier, are veterans with ALS that are in their final years in life. And it's a great disappointment to us that we cannot figure out a way to provide them the full care that they earned and deserved.
Thank you for that. And you mentioned, in your testimony that you thought there would just be really, there's a couple of hundred veterans, you believe?
Yes, ma'am. It's our understanding that it is only a few hundred veterans that are currently exceeding the cap, and that not all would require 100%. So you may have some that maybe need 70%, some that need 80%. Certainly, there are some that would need the full increase.
Very
And that
good.
number is stable from year to year.
Very good. And where did you get that data from?
From talking with our own members and then with conversations with VA.
Okay, very good. Well, the VA has promised me those numbers on the record. Mr. Brown, really this is a question for all three of you. So, there's a section in the bill, I think, that the VA is, not necessarily supporting, and that is about transparency and having a singular website with all of these services together on a website, so a veteran knows where to go and doesn't have to go to five or six different sites to figure out what programs and services are out there. One centralized location on a website to get that information. Do you think that's a good idea?
Absolutely.
Ms. Elliott?
Yes, I absolutely think that that's a good idea. I was an analyst in the Army, and I can find those things, and I can spend all day on that. I'm also a veteran advocate, so it's kind of my job. So, but my wife has 5 head injuries, and for her, if she's going to look for any resources, if she has to go past 2 clicks, it's not going to work.
Yeah.
So in order to benefit our caregivers and our veterans, I think that it's not a hard ask to have them all in one location.
Very good.
Yes, we agree too. I think the veterans' experience, as VA speaks about it, should be as simple and easy and streamlined in the virtual world, along with the VA healthcare that they get.
Yeah, I think, Mr. Brown, in your written testimony, I think you had a case where there was a veteran was associated with a medical center that had the directed care program. He needed that program, but the two never came together.
That is correct. Actually, that was our national president.
Oh, my goodness.
That was, he's currently in a home health program, and it wasn't until last year that we realized that veterans-directed care was available at the facility that serves him, and he had a little bit of difficulty contacting the staff, but when he did and inquired about why he wasn't, offered that program, they told him that they felt that he probably would have difficulty finding the workers that he needs to care for him. But in fact, the opposite was true. He actually had people that were willing to step forward and care for him, and it would have been an ideal situation for him to participate in that program.
Terrific. Thank you so much. I yield back, Madam Chair.
Thank you, Representative Brownlee. I now recognize Representative Von Norden from Wisconsin for 5 minutes.
The angry senior chief. I'm just fun kidding, man. Hey, Mr. Retcher, I understand you support the bill that I don't, and it's not that I don't support the whole thing. It's just I don't want to grow the bureaucracy. Having the term longer for the secretary, I think, is a great thing because it does get rid of that gap. But again, we need to work for efficiencies. Ms. Ellett, is your wife a vet?
Yes, sir.
Is she getting taken care of now?
Yes, she is.
Where does she get seen?
We both go to Richmond VAMC. We're also rural veterans,
So am I, yeah.
it takes us about 45 minutes to get to a local CBOC,
Okay.
and about an hour and a half to get to the VA Medical Center. So when we make appointments, we make them all day, make them
Yeah.
for the whole day, and it's a day trip for the both of us.
Have you had problems getting access to community care?
Yes and no. Some of the community care providers are very, we get the referral quickly, and some of the community care providers are very helpful and very willing to work. Working through a third-party administrator is a little bit difficult
Yeah.
because they have you on the phone and they have somebody else on the phone, and so we have had those same-day struggles. However, when we do schedule for like our CBOC, it's immediate. We can call and schedule an appointment like that. It's the community care appointments that have the real problem with the same-day scheduling.
Okay, well, thank you for that. And you know that you have friends here on this committee, right?
Yes, sir.
Okay, and I'm a Legionnaire myself. HR 562. Does anybody on this panel believe that the VA cannot find space for us to see veterans that come in to visit to hopefully get care and benefits? Mr. Retchell, let's start with you.
So DEV is a resolution-based organization. We don't have a resolution that supports that. However, in our experiences that we have, I think that's something that Congress can definitely look into with the administration to see what spaces they have. We know that they have some challenges with regards to some localities not having the conference rooms available and things of that nature, but
Yeah.
definitely we would be willing to work with you to see if we can assist that process.
Okay. Ma'am? Army guy? What, were you an intelligence analyst? You said you're an analyst?
Yes, I was an intelligence analyst.
What was your MOS?
35 Fox.
Okay, roger that. Did you go to Huachuca?
I did.
Okay, check. So do you think we should be able to see our fellow vets?
So we have a lot of veterans that, first, thank you for that question.
You're welcome.
We have a lot of veterans who do communicate with our Congress individuals, especially our rural veterans. They would like to interact more due to, more representation opportunities. However, we don't have a specific position on that. We are talking about taking it back to our members. It would be nice to have that kind of direct communication. As far as space, I know that I've been to quite a few VA facilities, and they are struggling to find space for their services. However, it's going to be a compromise. So if that's how they move forward, then I'm sure that we can all figure it out.
It would be awesome if you brought that back to our fellow Legionnaires.
Absolutely.
Because I honestly believe, I think they're afraid of oversight. Sir, Mr. Brown?
So availability of space is always a perennial concern in VA. It sounds like we're all in agreement here. PVA didn't take a formal position on this bill.
I read your stuff.
Generally supportive of it.
Okay.
And like DAV, we certainly would hope that the committee and VA will be able to work something out.
Excellent, thank you. So I'd like to go on a record again to say that the vast majority of my health care provided by the VA is excellent. I'm incredibly proud of my local office in La Crosse. I also go to Toma. That's where that whole the drug stuff started. I'm very, very proud of them. I'm also very proud of you. And it takes a lot of guts to come here and speak in front of these committees, and you're doing a good thing. And you're helping my brothers and sisters, of which you are also. So God bless you guys, and you take care and take care of your wife, will you? All right, with that, I yield back.
Thank you, Representative Von Von Orden. I now recognize myself for 5 minutes. And I'll just go down the panel. Do VSOs have space in VA medical centers, Mr. Retzer?
So for the DAV, we are fortunate to have space where we have our transportation program that's in there with our hospital service coordinators. And at the same time, many a times we have the VAMROCs, which have national service officers co-located inside, or we have national service officers that are close by at federal buildings.
Ms. Ellett?
Thank you. Yes, so we do have some space. We share typically with other VSOs. We have our representatives or our service officers that do have space in most VAs, usually with DAV or PVA in the same office.
Mr. Brown?
Yes, ma'am, PVA does have space in many VA facilities. The majority of those are the spinal cord injury centers and the hub locations.
So having been a nurse who worked on the neurosurgery floor at Walter Reed, I'm glad that you have some space, but it also seems to me that if VSOs have space in VA medical centers, that members of Congress who want to meet with their constituents and fellow veterans should also. So thank you for your candid answers. Ms. Ellett, in your testimony, you mentioned that many medical centers are trying to make the scheduling process easier, but it varies from VISN to VISN. What are your members' experiences when trying to schedule an appointment via a call center?
Typically, call centers will have to, they have to log out of one VAMC and into another area, which usually takes more time. And there's also more confusion with that. Like I said, that there is a pilot program that's, I think it's in VISN 8. And it is a call center that has that one screen. And it's able to combine 14 VA instances. So, a person doesn't have to log out of one and log into another, so it makes it a lot easier. But there are some, it depends on the VISN. There are some that are very responsive. There are individuals that are very willing to assist and move mountains to help make those appointments happen. And there are others that are less motivated.
Yes, thank you. And I also provided community care and took care of veterans as part of my practice. And you had mentioned that many community care referrals require multiple phone calls to establish an appointment. So how can this bill impact that process, and is there anything we need to add?
With that bill, we're hoping that with that bill, there's more of the technology of the pilot might happen, and you would also have the buy-in with the community care providers. But I think with this legislation that we don't want to get lost in making an appointment happen that day or scheduling an appointment that day, but losing any quality. We don't want to lose any quality of care or any kind of anything to take care of the veteran. We don't want anything negative, any negative impact with it. So that's what we're concerned about.
Understood. With the PACT Act increasing eligibility, I'm even more concerned about scheduling processes and delays in cares. Many veterans prefer online portals and direct scheduling. Even so, these sites often require veterans to follow up with phone calls. And if you miss the phone call, sometimes you miss an appointment. Does the bill require any additional language to apply to these types of scenarios, and what type of oversight would be required to make sure the VA implements this bill if passed? Like I said, sometimes when you create the will, they find a way.
Thank you for that. I think that maybe adding an additional timeline for a follow-up to allow that room for those specific ones. I know that personally, getting community care for a GI appointment is impossible to schedule the same day. So I think that having a timeline for the after, any follow-ups, and then keeping oversight of those tracking, that's where, kind of the Transparency Act would come in.
Excellent. Thank you so much. I yield back the remainder of my time. Ranking Member Brownlee, do you wish to make any closing remarks?
Well, thank you for that. No, I don't really have any closing remarks, except I'm excited about this hearing. I'm excited about the Elizabeth Dole bill, obviously, but there are many other good bills here. So I thank the chairwoman for making this hearing happen so we can begin to move these bills along in the 118th Congress. So thank you.
Thank you. I look forward to working through these issues and many more with the department, with my colleagues, and with the ranking member and the members of this subcommittee. The complete written statements of today's witnesses will be entered into the hearing record. I also thank all of the witnesses for making the time and the effort to appear before us. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Hearing no objections, so referred. I thank the members and the witnesses for their attendance and participation today. This hearing is now adjourned.